Hey, we've been recording some of our videos now.
Okay.
You okay with that? It's fine.
Yes, I'm okay with that.
All right.
All right.
Just smile. That's right. Smile and wave.
All right.
DRG validations. So the learning objectives for this course today, the CDI Specialist or CODA will be able to define what DRG validations are and what the CMS DRG Coding Validation stance is, what their take is on that. Understand the coding guidelines associated with DRG validations. Discuss the role of DRG denials with DRG validations. And then we're going to review the most common diagnosis associated with DRG validations, as well as evaluate the query practice brief update from AHIMA and ACDIS. And then we're going to also look at two sample appeal letters, one for a hospital setting and one for a provider setting. And then we're going to discuss various case scenarios with the most common diagnoses associated with DRG validations. So our disclaimers. The presentation is designed to provide tools to communicate information about clinical documentation, coding, and compliance in an educational structure. The presenter is not providing or giving legal advice or assistance, but offers sensible and useful information and tools to obtain compliant results in the area of clinical documentation and coding. The educational materials provided in this presentation are carefully explored for its accuracy and usefulness. Best practice results and achieving outcome will differ in each hospital facility and every clinical situation. So let's look at DRG validations. So what does that really mean? So based on the definition, it's all diagnoses and procedures that are billed accurately based upon official coding guidelines and regulations as set forth by the 4 cooperating parties. And those 4 cooperating parties are listed here. It's your Center for Medicare and Medicaid Services, CMS, your American Hospital Association, AHA, and then of course your American Health Information Management Association, which is AHIMA, and your National Center of Health Statistics, also known as NCHS. The goal for DRG validation is to validate all diagnoses and procedures that are clinically supported within the medical record, and the clinical documentation within the medical record supports every diagnosis and procedure performed. That's our goal. So what are the reasons why we do DRG validations? Well, it's compliance, right, with rules and regulations associated with hospital admissions for all the diagnoses and procedures that were performed during that stay. We also confirm all diagnoses that they were correctly coded with POA status. Of course, that's our present on admission status, right? So that's really important. We want to make sure that we get all that accurate capture of POA and not POA. Review for potential hack if not listed within final coding. And then verify discharge status code and all other data elements affecting DRG assignments. Now, when it comes to your discharge status code, usually that's the coder's responsibility. I put it in here because I think it's important from a CDI point of view that you need to know if this patient, was the patient discharged home as self-care, or did they discharge them with home health? So sometimes when a CDI specialist is doing their last review, it's really important to see what the doctors are ordering and what they're listing within their last progress note prior to discharge to say, hey, we're probably going to set up home health for this patient, therapy or nurse eval or whatever. Okay. So I think it's really important that the CDI specialist keeps an eye on that for every patient upon review at the end of the review or your last review. Now, our DRG approved rack listing examples. Now, these are just a couple examples that I pulled right from CMS. As you can see, the inpatient hospital MSDRG coding validation, that's the most complex. And it's all MACs, which are your Medicare audit contractors. Those are the ones that review for all inpatients for medical necessity to make sure they're meeting medical necessity to stay in the hospital. It's all across the board. And this is all national. And this has been going on since 2017. Now, believe it or not, if you take a look at number 2 and number 3, these are all outpatient. They're ambulatory surgery. So they are monitoring them as well. And then the last one, of course, is your SNFs, your long-term care facilities. So that's really important that they capture that information as well. So CMS DRG Coding Validation stands. So this is what CMS states. MSDRG coding requires that diagnostic and procedural information and the discharge status of the beneficiary, as coded and reported by the hospital on its claim, matches both the attending physician description and the information contained in the beneficiary's or the patient's medical record. Reviewers will validate MSDRGs for principal and secondary diagnoses and procedures affecting or potentially affecting the MSDRG assignment. Coding changes may result in a partial overpayment or underpayment. So non-receipt of records will result in a full overpayment. Review of length of stay and clinical validation is not permitted. So they're going according to what the claim has been submitted with the diagnoses, your principal diagnosis, any secondary diagnosis, your comorbidities, and then they're looking at it, okay, are they appropriate? Is the information in the record to support that diagnosis? They don't clinically validate that information though. So let's take a look at some of your ICD-10 CM coding regulations. So we have numerous, there's a lot of conventions that the coders have to abide by. And I think it's important from a CDI perspective that we just have an idea of what some of these coding conventions are. So there are, of course, the alphabetic and tabular indexes. Those are our ICD-10 CM codes. There's an alphabetic listing further subdivided into index of diseases and injury, index of external causes of injury. They also have a neoplasm table and a table for drugs and chemicals. Now your code structure, as we know, they're in alphanumeric characters and it could be 3 to 7 in length. And the code reporting for the 7th character this is a unique code. This is where your qualifier code comes into play. Mainly you see this in the procedures that are performed, like for a kidney transplant, your 7th character may be, is it a living donor or is it a donor, a cadaver donor? Your placeholder character is denoted as an X, and this utilizes the 7th character for the completion of the code. So you can have an X in there as a placeholder or a Z, and that's usually your character 7. Abbreviations, NEC is not elsewhere classified, and NOS is not otherwise classified. We always see these codes, right? We always see the NEC and the NOS codes within the codes that we're doing when we're doing our clinical validation, our clinical reviews for the records. Now, punctuations, these are brackets that are used to specify manifestation codes, and parentheses are used for supplemental words or non-essential modifiers. That's why they're all grouped together. They'll tell you that the brackets, there's a specific manifestation code associated with that diagnosis, and that'll be listed as such. Other codes, there are certain conditions not listed in the alphabetic index, thus the word other is used for the specified diagnosis. And of course, we have unspecified codes. And this is documentation in the medical record. Is it sufficient to come up with a specific diagnosis code for that diagnosis listed by the provider? When it comes to additional conventions, includes notes. They appear under the first 3 characters of the code for further specificity of a particular diagnosis. And then excludes notes. There's two types of excludes notes. Excludes one indicates not coded here, and excludes two indicates not included here. So when you have an excludes one note, think about a diagnosis that may be inherent to that particular diagnosis you just put in your 3M encoder. For example, like your acute pulmonary edema, it's inherent to an acute heart failure diagnosis. So it'll tell you excludes one. You can't add that acute pulmonary edema diagnosis within your 3M program, your DRG program. Now the excludes two notes, however, this is where you may have a potential query to be associated with the diagnosis that you're putting into your DRG software program. So that's something that you really want to take a look at when it comes to your edits, your CMS and nosology notes. Now, your etiology manifestation codes, we discuss this all the time from a CDI point of view, right? The etiology or the underlying condition is sequenced first, followed by the manifestation codes, which are the associated comorbidities. This is, you have specific code structure relating to this. And this is one of the general coding guidelines that CDIs need to be aware of. So your manifestation codes, however, are never used as a primary diagnosis. If it's a manifestation code, and it'll give you the manifestation code in parentheses based on the other coding regulations and conventions, you never use a manifestation code as a PDX. That's a no-no from coding rules. Now, when you have use of and, or, with, see, and see also, this indicates that it's a causal relationship with a specific diagnosis listed as the PDX. So you can capture all of these additional codes with that particular verbiage by the provider. Now, your default codes, this is an unspecified term, is used with the diagnosis code when further specificity is not documented. So like appendicitis, for example, doctor wrote appendicitis to undergo appendectomy. Well, is it acute or chronic or what? What is it, right? So that's when it defaults to appendicitis unspecified. And from a CDI point of view, we never want to see an unspecified code. We try to capture all specified codes, you know, for the coder, and it's just quality with the quality initiatives that are out there as well. Sometimes you may be stuck with an unspecified code, but you really want to try to dig deep to get it further specified. And then your code assignment and clinical criteria. This is based on the provider's diagnostic statement that the condition exists. If conflicting documentation is found, a query needs to be sent to the provider to clarify the conflict. Now, just an FYI, when we were doing queries, and I can mention this later too, while I'm thinking of it, I was on the Pinson and Tang webinar yesterday, or a couple days ago, and they were mentioning about, you know, query being sent, and they were discussing, well, instead of sending it to the attending provider, you send it to the consult. And in certain situations, you may have to send a query to the consult, right? Especially if it's a surgeon. You know, the attending provider is not going to know what occurred during the procedure, right? Or you need further specificity for that procedure code. So really, it's important to keep an eye on that, but also follow what your facility policy is, what their protocol is for queries, sending to attendings and or consults. Okay, in addition, general coding guidelines, we want to locate the code within the alphabetic tabular indexes. And of course, it all goes back to your provider documentation. And you code to the highest specificity by using characters 3 through 7. So more specific code is based upon provider documentation. Now, your signs and symptom codes are acceptable for principal diagnosis if no definitive diagnosis was confirmed. And we all know that from a CDI point of view. And there are codes that are integral to certain diagnoses, so we don't code those. Like the example I just gave, acute pulmonary edema is inherent to acute heart failure. And there are codes that are not integral to certain diagnoses, so we can code those. multiple coding for a single diagnosis. Use additional code that are not part of the etiology manifestation coding rule. So there are other codes that you may be able to capture from the etiology and manifestation coding rules. So you can capture those. Like I said, you always want to go back to your nosology, your edits to see exclude one. You can't code that here. Or is it an exclude two? Then you'll be able to code it. Acute and chronic diagnoses or conditions. This is where your potential queries are also available if severity is not documented by the provider. And then your combination code reporting. If a code doesn't have the specificity for a manifestation or complication, a secondary code may be used. So that's one example that comes to mind all the time. Your hypertensive heart disease with acute heart failure. Your secondary diagnosis would be specified as your acute diastolic heart failure, for example. And then say they have CKD with that, then you list your CKD stage or end stage renal disease. So that's where the combination coding comes into place. Okay, and these are some of the interesting ones that that everybody gets a little confused on from time to time, and I know I do from time to time from a CDI point of view. Your sequela diagnosis. There's no time limits to use on sequela codes. Usually they occur after the acute phase of the condition or diagnosis. So what comes to mind there? An acute, right? Acute CVA with right hemiparesis. The right hemiparesis never goes away from their old stroke. So now you have that. You can use that code as a secondary diagnosis. And probably they're getting some type of PT or they're getting assistance, so it can capture for treatment as well as a secondary. Now, your impending or threatened diagnosis. So if a diagnosis did occur, then you code the diagnosis as if it did confirm, you confirmed it, you can code it. If it didn't occur, use codes for threatened and pending per coding references. So now we do have codes for threatened or impending diagnoses. So that's something that is fairly new, that just came up now. I think it's the past couple of years or so they've added that in. So that's what, you want to keep an eye on those and monitor those diagnoses, those conditions to see what really happens. Even though they said impending, did it happen after the fact? Did it occur? So that's why you want to confirm any of those diagnoses when they're listed as threatened or impending. Laterality, we all know laterality is very important. It's either left, right, or bilateral, and a potential query, if not documented by the provider, is needed. And then documentation from other clinicians. Now, this is where your nursing, wound care nurses, your registered dietitian, even your case managers and social workers, and they also added in the therapists now, your physical, occupational, and speech therapists, that they can pull in other data. The coders can pull in data from these other clinicians. We can get, of course, the BMI, the wound care stages, the depth of non-pressure ulcers, your laterality, your SDOH, that's your social determinants of health. That's now a big thing. So where all your Z codes are. And CMS and all the other three cooperating parties, they're looking at that. They're gathering that data currently. The coma scale, of course, and your NIHSS, which is your stroke score, is very important to list in your coding. As a CDI specialist, if a patient comes in with an acute stroke, you definitely want to list that IHSS score within your encoder. And then, of course, your blood alcohol level. Now, your syndrome diagnoses, the coders have to follow the alphabetic indexes. So there is specific information that they have to follow in order to capture all those syndromes. And if no specific code is available, then the coders will code the manifestations associated with that syndrome. And of course, your complication of care diagnoses. Documentation must specify the cause and effect relationship and the clinical significance of the complication. If it's not specified, a query needs to be generated. And I know a lot of CDIs, they get a little nervous. They get uncomfortable with sending a complication query. But I think it's all about putting it all together with your three-legged stool and making sure you have everything listed out there for the provider. Because little choices like, is inherent to the procedure, is an associated complication, is not a complication, or whatever. Little verbiage goes a long way, but that word inherent too is always great for any complication queries. Okay, and the last general coding guidelines or conventions that the coders will look at is borderline diagnoses. Your code has confirmed using the borderline diagnosis code, so that's really important, especially if they're doing treatment for it. They did a workup and they did treatment, you would definitely want to code that diagnosis. And the use of external causes for conditions or diagnoses. All injuries should be specified with an external cause if known, especially your trauma patients, right? The traumas that come in the door with the your MBAs, or an older person who fell and they slipped and fell and they broke their hip. We want to know what the cause of that fall was. Did they slip and fall? What were they in the kitchen? And the coders have to pick up all those external codes. As a CDI, do we really need to pick it all up? Not necessarily. I usually like putting the whole picture together, though. From when I was doing CDI reviews, I would put the whole picture and I would include all these, as well as your Z codes. I think use of Z codes is very important today, based on the quality initiatives that CMS and the other cooperating parties are, what they're looking at. And the quality initiatives are associated with your SDOH, your social determinants of health. Homelessness is a big one, your financial impact. So it's really important that you capture that information. Even if the COVID too, right? COVID-19, did they receive a vaccine? Did they have a history of it? Those are really important to capture because that does play a role in other chronic conditions. All right. So when it comes to your Z codes, code assignment is appropriate based upon healthcare services and or additional patient information relating to the encounter or episode. Some of these patients who are coming in, who came back in with COVID-19, they got reinfected again by it, but they had other symptoms associated with it. So it wasn't really the COVID-19 that was the forefront, the acute phase. It could be just a chronic condition. It's a chronic virus they have, but they develop gastroenteritis or they develop myocarditis. That's what brought them in the hospital. One of those acute phases, but you still had the COVID listed because they are still doing some type of treatment. And usually they're given the multivitamins, or they may be given even IV or something, depending on what state they're in and how severe that COVID-19 virus is. All right, now that we got through all the regulations and the conventions for ICD-10-CM guidelines, let's take a deeper dive into our DRG denials. So when it comes to DRG denials, they go hand in hand with DRG validation reviews. The most common issues found is incomplete documentation or inaccurate final codes. The bottom line is why? They want to save money, right? So how do we combat these DRG denials? Well, as a CDI specialist, we're the first line of defense for DRG denials. That's why you want to confirm all diagnoses listed by the provider, that there is clinical evidence in the record to prevent a diagnosis or procedure denial for that claim. Coders are our second line of defense. Informed of revised, updated coding rules and guidelines, so they monitor all that stuff. That's why they can take a look at that. And then they're going to confirm all the diagnosis and procedures performed and specified in order to capture the highest level of code specificity. So the more specificity that we have as the first line of defense, CDI specialist, the coders come in and say, okay, well, we got more specificity. It's in there. We can code it to the highest specificity for those particular diagnoses. And then they go according to what the coding rules and regulations tell them to code, if there's any other edits or excludes one notes, things like that. And then the third way is appeal letters. Especially when the medical record has the clinical evidence to support the specified diagnosis or procedure listed, the hospital needs to go after the insurance to get the money. That's where your appeal letters come in. Now, it's not just hospitals that are getting denials. Provider offices are getting denials as well. So common cases that we may see for denials, your short stay, right? Your short stay medical cases. There are cases when the patient is admitted as an inpatient but doesn't meet the criteria for inpatient admission. Well, who follows that? Who monitors the inpatient stay? Well, that's your case management, your care coordination department. They look at interquel criteria, or I think they have newer criteria today. Excuse me, besides the interquel criteria that the case management care coordination department utilizes to say, does this patient meet medical necessity for inpatient? And that's why sometimes you may see different orders flip, like the doctor will admit him, the admitting doctor admits him to admit patient, and then the next day they change him to observation inpatient status. Cases with only one CC or MCC, this is a big red flag because it increases, right? Your CC or MCC capture will increase reimbursement, but the auditors will definitely focus on those particular diagnoses, especially when if you only have one CC on one case or one MCC on one case. The other pieces of the pie, the unrelated operative procedure MSDRGs, that's what I call the MAL, right? It's a principal procedure not associated with your principal diagnosis. And the MSDRGs are 981 to 983 and 987 to 989. These DRGs have a higher relative weight, therefore higher reimbursement. And I think most hospitals, if I'm not mistaken, I know at Henry Mayo where I worked, the coding supervisor would have this in a QA pool prior to the claim being submitted for billing. And there was always a flag for these particular DRG assignments. The other thing is the outpatient procedures on the inpatient only list. There is a Medicare list for inpatient only, believe it or not. And the patient, if the patient is admitted as an inpatient and the procedure is not included in the list, the admission will be denied. So the doctors really have to specify out, why are they admitting the patient if it's an outpatient procedure? So you really want to keep an eye on those patients as well. That's like patients who may have lens implant, right? They take the cataract out, put a new lens in the patient, well, they develop a problem. Well, the problem is what bought the bed for the hospital stay, right? So they went into a rapid atrial fibrillation. That's really going to be your diagnosis for the inpatient admission, not the cataract or the lens implant procedure.
So that's why it's very important for the doctor to really clearly document why the patient is admitted as an inpatient. Because if it's not on that list, they will deny the admission. And you cannot go back and say, no, this is an outpatient. They will, the whole admission is going to be denied. So that's why the case managers are very keen into this to find out whether they have, they have a list. So they look at the list and if they're doing it for a long time, they know already what is an inpatient. Usually the laparoscopic ones are outpatient. So
Right.
they would know right away whether they could convert this to an observation or outpatient rather than inpatient, because the whole admission will be denied.
Right. Okay. So some of the common diagnoses that we may see with the DRG denials, well, denials occur, first of all, because of what? Insufficient, inconsistent, conflicting documentation within the record from any provider who is part of the patient's care during the inpatient encounter. So queries or clarifications need to be generated for any conflicting, inconsistent, or insufficient documentation in order to confirm or reject the diagnosis listed by the provider. So what are our red flag common diagnoses that we see? Sepsis, severe sepsis, your acute metabolic encephalopathy, of course, your acute respiratory failure, whether it's hypoxic or hypocapnia. Severe protein calorie malnutrition is another one, as well as pneumonias, UTIs, even acute renal failure and acute blood loss anemia, believe it or not. So let's review some of the most common diagnoses for potential denial. So when it comes to sepsis, sepsis is what? A syndrome comprised of signs and symptoms associated with an infectious source. So now sepsis 2 criteria is used by CMS, right? And that's part of the core measure reporting. So that's where your quality department gets involved. And they submit this information after the patient's discharged if they have this diagnosis of sepsis and if they meet the criteria to be included within the sepsis core measure reporting. So sepsis 2 is SIRS plus source of infection sepsis equals sepsis, right? Our SIRS criteria though. So you need to have at least 2, right? At least 2 with the associated infection in order to qualify for a sepsis diagnosis based on CMS criteria. However, most commercial payers are using sepsis 3 criteria. So what is sepsis 3? So this is a score that is assigned to the patient based upon sepsis criteria with acute organ dysfunction. So the score is based on numerous factors, and it's usually related to respirations, your blood levels of your platelets, your bilirubin, your mean arterial pressure, that's relating to your blood pressure, right, that we know of, creatinine level, and your Glasgow Coma scale. The key point here, always clarify or query the infection source if not documented and linked to the sepsis diagnosis, as well as making sure there is acute organ dysfunction diagnosed and linking that information to sepsis as well, so then you can get your severe sepsis diagnosis. Now, they're trying to go away with sepsis diagnosis. CMS and the other cooperating parties are looking at, okay, maybe we just have severe sepsis and septic shock. So that's where your sepsis 3 is, right? That's what they're looking at. So CMS is looking at that. They didn't rule it out yet that they're going to go to sepsis 3. They're still reviewing that. So they're still gathering data. So sepsis 2 criteria may be gone in another year or two, and everybody was going to be on sepsis 3 criteria, even though the providers don't like that because it doesn't give them advance notice and early warning that the patient may be getting septic with sepsis 3 criteria. So it's really interesting to see what's going to happen over the next 2 years with the diagnosis of sepsis and what criteria CMS and the cooperating parties may use.
Yeah, it's also very important with sepsis because sometimes, with the Medicare sepsis 2 criteria, their criteria is like 2 out of the the temperature or the WBC. But for example, the patient has AFib with RVR, rapid ventricular response, also tachypneic, and has let's say a UTI. So you need to balance, is it because of sepsis or because the patient's just having that other diagnosis, that's why the heart rate is elevated and could qualify to the criteria. So in our facility we need to be very careful when we try to query the doctor about sepsis. You have to really look at the whole picture if the patient is really septic. But I mean, you just need to query, it's up to the doctor to say, oh yeah, the patient's septic. So like sometimes we get response from the doctor saying no sepsis. So at least we clarified with all the criteria that we have whether the patient has sepsis or not.
Right. You did your due diligence, as we say.
Mm-hmm.
Right? So this is the SOFA for sepsis 3 criteria. As you can see, what we just mentioned on the other slide, the respirations, your platelets, billies, MAP, and your GCS and your creatinine. I think it's important that, sometimes I used to have a little cheat sheet of this listed in my in my cubicle when I worked in the hospital setting, because it does help you. And as a matter of fact, sometimes even having copies of this to share with the providers goes a long way. We did put a little brochure together, a little tip sheet, but we created this little postcard with this information for the providers that they can have it, they can carry around with it, or they can leave it in their office. So it's always available to them. And they really, I think a lot of the hospitalist teams really appreciated that because they had it right at their fingertips. And I think it's really important that all the providers should have that information. It'll definitely help them understand where we're coming from a CDI and coding perspective.
Yeah. So it's so simplified. This the SOFA, because you, as you could see, there's no lactic acid here. There's no vital signs except for the respiration. So it's very broad how they could define sepsis. But we just need to follow what our facility are asking us or are using to define sepsis. So I think it's just the what do you call it, private insurances that are using the SOFA.
The
Most of the
commercial,
time,
yeah,
the commercial. Most
yeah.
of the time, the inpatient hospital or facility are using the sepsis too, since their payer is Medicare, so they
Sure.
they have no choice but to use that.
Correct. Okay, so when it comes to severe sepsis, of course, this is sepsis with acute multi-organ system dysfunction, right? So you're going to look at what are your clinical symptoms. You usually have hypotension, you got a lactic acidosis. It could be acute kidney injury, acute lung injury, or coagulopathy. That could be some of those symptoms that are developing, and that could be your acute multi-organ system dysfunction, your multi-organ failure, so to speak. So when it comes with severe sepsis, you want to see, is it with shock or without? So sepsis-induced hypotension is defined as a systolic BP less than 90 or a mean arterial pressure less than 70. That usually responds to fluid resuscitation. However, if they don't respond to fluid resuscitation and they're continuing to be hypoperfused, they're going to need vasopressors, right? They're going to need some IV dopamine, dobutamine, Norep, whatever the case
Levo.
may be,
Mhm.
Levo. So sepsis-induced hypertension persisting despite adequate fluid resuscitation, leading to hyperperfusion and requiring vasopressors, is your severe sepsis with septic shock. Now, your key points here, there are 2 codes that are required for severe sepsis. Your first code is related to the systemic infection, second code related to severe sepsis, and your additional code related to acute organ dysfunction. The key is they must be linked by the provider. If they are not linked by the provider, a query should be sent to confirm that information. All right, let's look at some encephalopathy here. So usually the main ones that we see, that I have seen even with DRG denials, is your acute metabolic encephalopathy or your acute toxic encephalopathy. Now, your acute metabolic encephalopathy is a short-term issue, right? It's transient. It's usually reversible and resolves when the underlying condition is corrected. So what could be the causes? Well, fever, dehydration, electrolyte imbalances, maybe hypoglycemia, infection, organ failure. Key points: linking the underlying etiology to the encephalopathy diagnosis. Monitor for documentation, return to baseline mental status. That's your key. That's your goal. If they come in confused, they have AMS, and they're like, well, it's an acute encephalopathy, we don't know what the problem is, and it goes on for a couple days, and all of a sudden they're back to baseline. The family says, oh no, they're back to themselves, mom's back to herself. Then you want to, and the doctor documents that, you definitely want to get the link if it's not documented by your provider, what type of encephalopathy is out there and what was the cause of it. Now, your acute toxic encephalopathy is the same thing. It's short term, it's transient, it's reversible and resolves when the underlying condition is corrected. So what are the causes that we see? Well, it's effects related to drug and toxins. It could be documented as a poisoning or a toxicity, right? one of the big things, unfortunately, that we see with some of these young adults is drug overdoses. You know, there's fentanyl out there. They're overdosing on the rainbow fentanyl or whatever it's called today. I don't know. But anyway, it's, it's sad, but you want to make sure that, yeah, patient's baseline status is back to normal. Mental status is back to normal. Definitely want to get that linked if it's not documented by the provider. And the other helpful hint, review thoroughly, especially if diagnosis included in dementia, delirium, sundowning, and it's the only CC or MCC. That's really important. And Jeremy, you had a question I saw, it came up in the chat. What did Jeremy have to say about the
Is respiration in SOFA related to hypoxia confirmation with the use of oxygen? Is respiration in SOFA related to hypoxia?
You want to
Yes.
go? I believe it is. I believe it's listed. in
Uh-huh.
there.
Yeah. It's usually okay, let me see here.
We'll go back.
Okay. Let's go back.
Yeah.
So the reason I'm asking the question is because normally we just use like just the respirations like 22, 24, 30, just the numbers. But you're using
Uh-huh.
We're doing the respiratory rate. Yeah. And that's
now
part
to
of sepsis 2. Yeah. That's part of sepsis 2 criteria. That's part of your SIRS
It is,
criteria.
but you want to make sure that it's being treated like you
Right.
know, is there oxygen being given, or is there some treatment by the respiratory therapist being given, to be sure that it will not cost for the denial, because at least when you say respiration is 24 and nothing's being done, is it because the patient's just anxious? Is it because of sepsis? So those are the things you need to look at. And for me, the most important is if there's a symptom, there should be a treatment.
Right.
To be, to be sure that there should be no loophole that the auditors will deny it, because if it's treated, it means it's important. That's it. That it's important for the patient's care. So that's how I look at it.
Yeah. Yeah. And I think it's important that, you got to go back to that 3-legged stool, right? When we're sending queries, what's the documentation? Did the doctor write the patient has hypoxia? Or are they just a little tachypnic because of anxiety? Or are they tachypnic because they're not getting the oxygen they need and they're putting them on a non-rebreather or something? Then yeah, do they provide or diagnose that patient with hypoxia? So that's something that you have to look at. You got to look at the whole picture to see exactly what is going on, and the treatment is really key for any diagnosis, because if you don't have treatment, that's like saying the patient had acute blood loss anemia, but there's no source. And they're documenting acute blood loss anemia. Why? Where did that come from?
Yeah.
Okay.
Okay. So let me just add, return to baseline mental status. The doctor usually do not document that, but you could see their documentation more alert or alert oriented ×3 or ×2. And then you could see that also in the nurse's notes. So it's nice if they could document to return to baseline mental status, but not necessarily that verbiage. You could just see what if, especially if I send a query, I'll just put there, what is the previous, like patient was admitted confusion on day 1, and then I'll say in day 4, patient alert and oriented ×4. So they know that the patient was confused and now the patient's back to baseline. So they could respond with encephalopathy. And I know coders were telling me when I was still at Memorial that the auditors are denying acute metabolic encephalopathy or acute toxic encephalopathy because this is an MCC. If the patient has, the dementia or delirium, they said, no, it's not the encephalopathy. It's because of the dementia, which is not a CC. Unless it is with behavioral behavioral changes, but acute metabolic encephalopathy is an MCC. So if they can take that out from the diagnosis, it's better for the government because it's going to be lesser reimbursement. So just need to be careful about that.
Yeah. Okay, and our other lovely one we have, acute respiratory failure, whatever type it is. So your hypoxia, right? What other causes? Of course, your respiratory infections. It could be a pneumonia, bronchitis, even COPD, exacerbation, an obstruction, trauma, or even a CVA, right? So the key point here, always clarify the type, if not documented by the provider, and the underlying etiology or cause associated with the acute respiratory failure diagnosis. You always want to have your clinical evidence to support that diagnosis. That's like with hypercapnia too, the same thing. Other causes listed for hypercapnia could be head trauma, drug overdose, or oversedation associated with pain meds. I've seen that happen, where the doctor, the attending provider wrote that patient was oversedated with pain meds, and because of his kidney function, he had CKD stage 4 or something, and they gave him some pain meds. Well, after he had his surgery, well, guess what? It put him into a respiratory arrest, and he ended up being intubated and sent to ICU on the mechanical vent for a day. So you definitely want to keep an eye on all that, but also make sure that your diagnosis and all your clinical evidence in the record supports that acute respiratory failure diagnosis.
Yeah.
Encephalopathy and dementia is considered mood change.
Oh, you.
Well,
Usually, yeah.
Go ahead.
Go ahead.
No.
Yeah, usually dementia with behavior mood change. Usually it's more of agitation, combativeness, aggressive behavior. So that is dementia with behavior mood change. Encephalopathy is different. It's more of a confusion. They could be agitated too, but if they go back to their base, because dementia, they do not go back to their baseline. Well, they could go back to their baseline. So it could be a combination of encephalopathy in dementia. That's why you have to really look at it. So the patient with dementia with behavior change, does it increase, okay, if they have dementia and they're just confusion, but there's agitation, and if they give some medication to combat that agitation, like Ativan, then probably it's just dementia. But if the patient has dementia with those behavior changes, but there's nothing causing it, like there's no clinical evidence that would cause the encephalopathy, like if there is no, let's say, dehydration or electrolyte imbalances, then I wouldn't query for encephalopathy. There should be a cause for that encephalopathy because it should only be transient. But like I said, dementia with behavior change, they could be less agitated. So does it mean the patient has encephalopathy? Not necessarily. You just need to see the whole picture. Is there something in the patient's diagnosis that could make the patient more confused rather than having agitation because of the dementia?
Does that make sense, Jeremy?
Yes, but
Yeah, I know it's kind of confusing.
and so and I've seen this a few times, is when I have a case where they say encephalopathy, and then they say above this is not their baseline for dementia, and then they go back later on in the documentation said patient baseline dementia now, but they do document the encephalopathy. It's related to encephalopathy.
Yes, so if that's what they said.
Yeah.
No. So what I'm trying to from your perspective is we have two different diagnoses, dementia and encephalopathy, but is the behavior, because we have a behavioral change that creates a CC versus it just being unspecified dementia. That's the kind of
That's
what
right.
I'm asking.
Yes.
Yeah, that's where
Yes.
that's what I'm asking. Is that
Yes.
would that be
So
inherent
yeah,
to
that's
that,
what.
or that's what I wanted to find out your perspective on that.
Yeah.
They're
So if the
documented
patient has
encephalopathy,
dementia, they're
and then they
documenting also
return.
encephalopathy, right?
Yes, and then they say they return back to their baseline dimension.
Uh-huh. So definitely that is encephalopathy because if there's a especially if they say because the patient has been confused has dementia on admission already, right?
Right.
So,
That is
but then
correct.
there is increase in confusion or there's increase in agitation, and then the doctor will document back to like dementia mental status, like what you're saying. Then I would definitely say there is encephalopathy there because the patient's dementia is back to baseline.
Yeah.
That's how
Because
I
you
look at
code the
it.
CC part of that for the dementia. That's what I'm asking.
Yes. Yeah. Uh-huh.
Yes.
Because, yeah. So dementia would behave if they document that, that's a CC, right? But if the doctor also document encephalopathy without unspecified is just a CC, right? But if they're more specific, like it's metabolic, then it's an MCC.
Right.
So you could code both because both are documented, both are being treated, right? And so you could code both of them, like I said, encephalopathy. It could be an MCC or it could be a CC. But if there's just unspecified encephalopathy, then you could code both the encephalopathy and then the dementia with a behavioral change.
Change. Yeah. As long as they specify the behavioral change in the chart, and if you can capture the metabolic encephalopathy, say what was the underlying etiology. So that's another potential query to say, okay, if they're writing acute metabolic encephalopathy, what's the underlying cause of that? So they're back to their dementia baseline status, right? And that's fine. So you can capture both diagnoses, like Christy said.
And another thing is you have to make sure. Go ahead.
No, I was just gonna say, like,
I can't hear you.
Yeah, we just lost this connection a little bit.
Okay.
Yeah.
Can you hear us though?
No, I don't see his internet is X'd out. Oh, there he is. He's coming back, trying to.
also just real quick, I was just saying that one of the cases I did not query for metabolic because there wasn't enough information to query. I just left it 2 CCs.
Okay, there you go.
Yeah. Yeah, because you know with encephalopathy, like I said, you have to be diligent about looking. Is there
Right.
a cause for encephalopathy? Or is it just dementia? Because encephalopathy need to have a cause for it to happen. Let me see here.
Type. Yeah.
Here you go. So there should
Yeah.
be like all this information here to be able to code to encephalopathy.
Right.
Like fever, infection, or because if the patient has altered mental status and there's nothing causing that to link it to encephalopathy, then I wouldn't even query,
Right. Correct.
or this is also a part of your validation to ask the doctor, is it encephalopathy or is it just dementia? So
Right.
that's what I'm gonna do. Okay.
Great question.
Okay. Yeah, yeah, it's very, very confusing because I know the coders are always asking us when there is a denial because that's what
Right.
you're saying is what the auditors are doing. So,
That's right.
so we know that is a problem. Yeah.
It's true. Yeah. So, okay.
And also with the respiratory failure, you want to make sure all those not because the patient has a hypoxia means the patient's in respiratory failure, right? We also have to see what are their symptoms. Is the elevation of heart respiratory rate? Is there any accessory muscle use? Because sometimes the doctor will document acute hypoxic respiratory failure, and then they'll put like on the lungs, no respiratory distress. So the patient is having a failure but not in distress, so you just need to find, to really dig into the chart and see what more information you could note that the patient is having really acute respiratory failure. So that's my dilemma. I got this patient, you know hypoxic, given out O2, and then they will document no respiratory distress, and then respiration is normal. So
Yeah.
you just need to follow it up. That's what I'm trying to say.
Yeah. Physical,
And also the red.
right.
Uh-huh.
Physical exam finding,
Yeah.
because then you can use that.
Yeah.
But this is what you're showing in the clinical evidence of the record. So,
That's right. Because sometimes they just copy and paste. So for example, the
yeah.
first day the patient was okay with normal respiration, and then they will just copy and paste. So, and then when the time comes, the patient becomes hypoxic, and there's still the physical exam respiratory, what do you call this, review is no respiratory distress. So it's conflicting.
Right.
So, and also red flag, make sure, when sometimes the doctor will just put their acute respiratory failure intubated for airway protection. Is it actually acute respiratory failure, or is it you're just protecting, the patient's respiratory status? So, that is also part of the what do you call this, validation
Patient process.
process, query. So that's another query opportunity there.
Okay. All right. And then severe malnutrition is another common diagnosis we see. May occur based upon inadequate nutrient deficiencies, that's lack of vitamins or minerals for that patient. And it could be due to acute or a chronic condition. So your causes, of course, as you can see, usually it's your type of cancer, your end stage heart disease, or liver disease, alcoholism, your diabetes, even malabsorption syndromes if they had a gastric bypass. And that's just a few causes that we outlined here. So your key points here is you want to clarify or query for underlying etiology associated with that malnutrition diagnosis, but you want to monitor for clinical evidence within the physical exam section of the progress notes. Some facilities will utilize the registered dietitian templates with aspirin criteria, and the provider may sign off on this document to concur with the diagnosis of malnutrition based on the RD assessment, but always ensure the diagnosis is written within the medical record as well, and not only listed on the RD assessment. We're Henry Mayo, we were in the process, I was in the process before I left, that we were creating the template where the doctor can sign off, like with the wound care nurses, stages for the different pressure ulcers. And then we said, you didn't put it in your note. You got to put it in your note. Well, they didn't. So it was denied because they didn't add it in their discharge summary or in a progress note. So the severe malnutrition was denied based on just being listed in the RD template. So always go back to your facility too to see what you have in place for your policies on that.
Yeah. And if your facility requires an ASPEN evaluation by RD, it's important that that the RD would really document that the patient has, let's say, severe malnutrition, so that when they wanted to audit the case, at least we have some indicators there from the registered dietitian that the patient really meets the criteria. So there is no chance for them to deny it, but they will try, of course.
Of course. And this is the aspirin criteria, just a table I found in today's dietitian magazine. I think it gives you a nice idea, nice little, information to have at your fingertips as a CDI specialist. But also, if you have the CDI pocket guide from Vincent and Tang, they do have this information listed as well. Okay, and then the 2022 AHIMA ACDIS practice briefs. I said just some updates here, the reasons why we're looking at it. Well, to support documentation of medical diagnosis or conditions that are clinically evident and meet the UHDDS requirements, but without the corresponding diagnosis or condition stated. So sometimes they may have all the information, the clinical evidence in the record, but they didn't use their big word and put the diagnosis in their assessment and plan. And you also want to resolve any conflicting documentation between the attending provider or other treating providers, whether it's a diagnostic or procedure code. You want to clarify the reason for the inpatient admission. You want to seek clarification when it appears a documented diagnosis is not clinically supported. That's where your clinical validation query comes into play. You may send a query to establish a diagnostic cause and effect relationship between conditions. Even establish the acuity or specificity of a documented diagnosis to avoid reporting a default or unspecified code. That's really important for CDIs today. And then to establish the relevance of a condition documented as a history of to determine if the condition is still active and not resolved. Sometimes if they're on, say they had a DVT, post knee replacement or hip replacement, and they're still getting anticoagulation and they're still doing PTINRs. I mean, they're doing diagnostic workup, they're doing treatment. You want to see if it's a chronic DVT for that patient. To support appropriate POA indicator assignment, to clarify a diagnosis is ruled in or ruled out, and to clarify the objective and extent of a procedure. Sometimes you may be missing one little character of that alphanumeric procedure code, ICD-10 PCS code, so you may have to send a query to the provider on that. And then this is for inpatient, the compliant query practice. You always want to have multiple choice answers, right? Yes and no answers are good if you're looking for POA status, and that's the only time I would send a yes and no. You want to make sure you have your clinical indicators to support the query option, answer options. That's your three-legged stool. What was the diagnosis listed, the documentation where that diagnosis was from. Your clinical indicators are part of your diagnostic workup with the diagnosis as well as your treatment. And then you provide specific date and time and provider name to all documentation listed within the query clinical indicators. And then, of course, all your clinical evidence within the medical record. As accurate as possible. I mean, you really want to get verbatim. You want to pull over exactly what they're saying in their notes when performing a clinical validation query for a specific diagnosis. And the key is you don't bring anything outside of what the record has. You keep whatever you're sending that clinical validation query specifically with the information you have available to you within that record. And appeal letters. This is just a quick overview of what the contents may include. Address the denial reason. Clearly state the documentation is sufficient to support the denied diagnosis. Convey why the codes are accurate. And always utilize the official coding guidelines or coding clinics to support the diagnosis in question. Request immediate recovery of the denial code and confirm the due date for the appeal letter, as well as confirm the correct address for the appeal letter. Sometimes you may receive a denial letter from a commercial payer where their address on the header is not where you're going to send the appeal letter to. It's listed in the body of the letter. So you got to make sure you want to send it to the right place.
And usually the denial letter is sent to HIM. And then after HIM, have the letter, then it's a collaboration now between, the coders, the CDI, and the case management.
Right.
Sometimes we also involve the physician assistant. So
Yes. And the providers, yeah, absolutely. And here's just a couple. This is a example that I received from ACDIS on the ACDIS website. This is for, it was an inpatient stay for the secondary diagnosis of lactic acidosis. You can take a look at it and read it. This is the first page and the second page is next. And just exactly how they set it all up. And it's always important to know respectfully, all the appeal letters for the first level appeal letters, we always had our HIM director, her name on it with her information, title, office number, etc. So that was always listed for first level appeals. And then second level appeals, we always had our physician advisor listed. And then this is just an example of a physician denial that they received. It was for a specific drug. They were trying to get the patient, and it's FDA approved, blah, blah, blah. So it just gives you a little example of what the providers are sending as well. All right, case studies.
So we have an 88-year-old male admitted for infection of the left total hip replacement. Patient noted to be lethargic, confused to person, time and place, no prior history of dementia or CVA. Past medical history includes hypertension, hypothyroidism, osteoarthritis. Orthopedic consulted, and patient will need to undergo the following procedure once medically stable. You have the removal of the left total hip replacement prosthesis, both acetabular and femoral, and insertion of tissue spacer. Workup revealed the following: CT head, MRI brain negative for acute pathology, and the treatment included neurology, neurochecks every 2 hours, assessment, infection of the left total hip replacement, and encephalopathy. Day 3, the patient still confused and disoriented, trying to get out of bed, ordered one-seater Ativan PRN. So what do you think would be our potential validation query here?
The encephalopathy.
All right.
Very good. Encephalopathy, right? Because, go ahead.
Oh no, go ahead, because I was actually looking at the and it's a cited, it's a surgical infection too.
Surgical infection, right? So let's see here. Because it is documented the patient had infection of the total hip replacement.
Yeah.
So
Okay.
that is given. So we know that it is, and that's what they're going to do the surgery for. But it is the encephalopathy that they documented. First of all, we want to make sure that there is encephalopathy because the patient is still confused and disoriented, right? So let's see here. Oops, sorry. Okay, we are in case number 2. Okay, yeah. Okay. So acute encephalopathy, if known, and key point return to baseline status documented in the progress note. So you're right. So the encephalopathy is our DRG validation here, right?
Yep.
Okay, the case number 2. 52-year-old female admitted with
Yes.
encephalopathy. Yep. So case number 2 is 52-year-old female admitted with melena, diagnosed with lower GI bleed. Patient has no significant past medical history and has noted watery black stools over the past several days. She did admit to feeling dizzy periodically after these bowel movements and has lost 25 pounds unintentionally over the past couple of months. She also stated that she really hasn't been hungry and just eating some fruits, vegetables. H&H 10.2, 37.3, 9.8, 35, 9.0, 34.3. Attending provider indicated the following diagnosis: melena, lower GI bleed, rural colon cancer, severe malnutrition, cachexia, with an intentional weight loss of 25 pounds, acute blood loss anemia. Plan is for nutrition consult for calorie count, GI consult for potential colonoscopy procedure, initiate IV at 125 per hour, start Megace BID, await GR consult for further recommendations. GI consult obtained and patient underwent colonoscopy procedure. Findings were significant for sigmoid colon cancer as well as descending colon mass, suspicious for malignancy. Biopsies of the sigmoid colon, ulcer, and descending colon mass sent to pathology. And then pathology report is positive for adenocarcinoma stage 2, recommendation is to undergo resection, general surgery consulted, perform excision of the descending colon with anastomosis up to the sigmoid colon. So what would be our potential validation query here?
Probably the anemia.
Anemia. Why do you say so?
Because I guess I don't know now.
Treatment.
So no, okay, so I'm saying anemia, but the
Right.
surgery is what's the treatment for the anemia. So do we need to validate that, or is it just to get? Well, I guess we do because of the blood drop.
That's right.
So
Yes.
it's
So
still within range, but it's still low. It's still within range, but it's
it's
still
still
low.
low, but it's not. Mhm.
Right.
Okay.
Yeah, so I would say that first of all, there is a blood loss, right? Because there's a melena going on. So
Right.
that is the source of infection, right? So and the doctor did diagnose I think GI bleed.
Yeah.
So we have that. But is it being treated, right? So we don't have any treatment. Or it could be, you could say the sigmoid colon, but it is a surgery for the carcinoma. It's not a treatment for the anemia. So they
No
did not
blood
give
transfusion.
any blood transfusion or
Right.
venifer or it's not documented here. So you want to
It's a
make sure
surgical cure.
that huh? I'm sorry.
Because it is a surgical cure.
Surgical
Yeah.
care.
Yeah, that's
You know what I
right.
mean?
So that would be so we have here the acute blood loss anemia and the significance of the path report for adenocarcinoma, right? So the doctor did document that there is the path report revealed adenocarcinoma, but the doctor did not document that. So it's just a query. It's not validation, or it could be validation, but it needs to be documented by the doctor. So
Right.
the doctor did not document in the diagnosis. So we could query that to make sure that it would be included in the patient's
Confirmed.
diagnosis.
Right.
And then the severe anemia, the severe malnutrition could also be another what do you call this potential validation query. The doctor did document severe malnutrition, but we don't have any what do you call this, any criteria.
Right.
Well, there of course there is a
Like the
loss of
BMI.
25 pounds
Right.
and the BMI,
Right.
but I mean, because not all low BMI means the patient is malnourished, right? Like Asian people have low BMI because they're just so petite, so tiny. So it doesn't mean they're malnourished. There's just a small body mass in their body. So it doesn't mean that the patient has what do you call this, is malnourished.
Right.
Also the albumin. They also look at the albumin. They also look at the muscle loss, things like that. Those are the criteria, I think, in Aspen before they could diagnose the patient to have severe malnutrition. So you just want to make sure to validate this by making sure that there is a dietitian documentation and what their diagnosis. Sometimes the doctor will say severe malnutrition, but then the dietitian will just say it's mild. So based on the criteria that they're looking, so you have to because severe malnutrition is an MCC, mild or unspecified malnutrition is just a CC. So these are the things that you need, especially this is a surgical procedure and you have an MCC of severe malnutrition. That's a lot of money reimbursement
Right.
because there's an MCC. So they'd rather have a mild because it's just a CC, but they're still gonna look at it. Is the patient really malnourished?
Right.
So they will be so to make the case stronger. so it wouldn't be audited. I think the dietitian documentation should be included in the medical records. It's like it's not mandatory in our facility, or some facility doesn't have a mandatory RD documentation. So I usually, if there's no if there's no RD documentation, I page them and ask them to evaluate for malnutrition. At least it's in the chart
Yeah.
that they evaluated, and this is what they I found. Okay.
And all the prior hospitals that I worked at, RD had to have an assessment done prior to sending any query for malnutrition, no matter what severity. That was part of
That's
the
right.
policy.
Mhm.
Yeah.
Because of what's going on with the audit,
Right.
they're denying it. So
So like in this
Okay.
case,
mm-hmm.
so just in this case, like this will be a case to me, like that patient will probably go home before he even gets seen by a nutritionist.
Yeah,
Could be, you know. Oh,
that's how bad it is.
No, like
Yeah.
you did the surgery, you cured the ulcer, you found out they got cancer, so you follow up with outpatient services on the cancer, and they're gone. So you still
So that's
need to follow up on the malnutrition then.
That's right. Yeah. I mean, well, like usually like this is a major surgery. It's not even laparoscopic. It's open. So probably they'll still. I
Oh,
would say
okay,
that the
okay, all right, okay, all
minimum
right,
is 4 days.
all
So
right, okay, that'll
Jeremy,
work.
you need to review on the second day. Okay.
Well, because like where we're at, the nutritionists might not even get to this case of like the second or third
Yeah.
day.
day.
Yeah.
Right.
I know what you mean, because sometimes if the
Yeah.
patient is admitted on Friday, right? Or let's say Thursday, Friday had surgery, Monday discharge. So there's no way for you to call the dietitian, right?
Right.
But but just saying, it needs to be validated, because there's a tendency for it to be denied.
Yep. Okay.
Okay, case number
Hey,
3.
can I
This is
ask a real
70.
quick question? Real one quick question.
Sure,
So
sure.
if they say malnutrition and the BMI is normal, like within normal range still, I still want to kind of do a follow up on that, right?
That's right. Yes, because
Okay.
BMI is just one criterion
Okay.
that they use.
All
So
right.
yeah, so you just need to follow it up, right? But that is my criteria to call the dietitian. If I see the BMI is low and the albumin is low, then I call the dietitian, and she
Yeah.
makes that assessment for me. So
Right.
okay, so case number 3, 67-year-old male admitted with shortness of breath, wheezing, dyspnea at rest. Vital signs revealed the following: with a temp of 101.2, heart rate of 118, respiration of 28, BP of 92/58. Past medical history significant for COPD. Home O2 dependent at 2 to 3 liters. Hypertensive heart disease without heart failure. Hypothyroidism and mixed hyperlipidemia. The workup revealed chest X-ray with consolidation infiltrates to the left lower lobe, right lower lobe, and left upper lobe. Blood cultures positive for gram-negative rods. Blood work notable for WBC of 18.2, lactic acid of 2.8, procalcitonin of 2.1, BUN of 20 with creatinine of 2.6. The baseline is 0.8. ABGs drawn on 2.5 liters supplemental O2, and the result is pH of 7.32, PO2 of 68, PCO2 of 45, and PF ratio of 286. Attending provider diagnosed patient with severe sepsis with acute organ dysfunction, COPD with acute exacerbation, bacterial pneumonia, acute kidney injury, lactic acidosis. The treatment includes pulmonary consult, continue with O2 2 liters, IV Sosin, IV Rocephin, IVs at 125 per hour after completing the IV normal saline boluses from ER, daily chemistry, and CBC. Okay, so what would be our validation query here?
The sepsis, severe sepsis.
Okay, what would be what would be your query? What would you validate?
Like the linkage to the, well, hold on. So I guess the first thing would be to, hold on. No, that's right. That seems right. So the with the kidney failure or the kidney injury.
That's right. So
Yeah.
because the doctor documented severe sepsis with acute organ dysfunction,
Right.
they need to specify what is the organ dysfunction, right? So you wanna query, okay, is the severe sepsis is AKI related to the severe sepsis, or is it the lactic acidosis related to severe sepsis? Because that would be your acute organ. I mean, in our facility, elevated lactic acid is an organ dysfunction for them. I don't know with other facilities, but to be sure, AKI would be an acute organ dysfunction. So very good. So severe sepsis. Do you have
And
anything else?
the COPD, is it exacerbated because they're within baseline for HOMO too?
That's right. And what do you call this? Also, is it being treated, right? So if he says CO2 acute exacerbation on 2 liters only, and the patient is on 2 liters at home, so there was no increase in the usage of the oxygen. And I don't think the patient is being treated with. So there's no
Right.
like usually they give the
Right.
patient like steroid, IV steroid,
Right.
solumedrol or solucortef, right?
Right.
So those are the two, and then oops, uh,
Yeah, I think that was.
yeah. So that's are the two that we are
No.
definitely looking at. Yeah. So, but I would also say the bacterial pneumonia. He said that, but we don't have a CNS. But probably take a look. Is it really bacterial or viral? Just check on the CNS if there is. Otherwise, it's their opinion, and that's how they're being treated. So we'll just have to leave it as that. Okay.
All right.
Okay, case number 4. This is 88-year-old female admitted as inpatient with complaints of burning sensation when urinating and abdominal pain. The son also noted urine is cloudy. Son stated that the patient had fever at home and confused. In ER, his vital signs are 102.4, 112/22. He has elevated procalcitonin level and lactic acid of 3. Urinalysis revealed WBC of 15, which is high, bacteria 10, high, epithelial cells of 7, which is also high. So, workup revealed blood work notable for WBC of 22.1, lactic acid of 3, procalcitonin of 2.1, and blood culture and urine culture pending. Attending provider diagnosed the patient with UTI, metabolic encephalopathy. Treatment includes IV Rocephin and Zosine, IV at 125 per hour, CT of the head without contrast. Hospital day number 3, urine culture positive for E. coli. Still having fever of 101, heart rate of 110, respiration of 18. MD ordered ID consult, continue current antibiotics. Hospital day number 3, afebrile, urine is clear, no complaints. So what would be our potential DRG validation here?
I would consider the query a query for the organism and possibly
Yes.
like sepsis.
That's right. And possible sepsis, right? Because UTI, and this is another case, right? Because the patient is admitted with UTI, and it doesn't meet the criteria for inpatient.
Mhm.
So that's why sometimes the case manager will ask, this patient doesn't meet the criteria for UTI to be inpatient. So can you take a look? And then you say, oh, the patient doesn't just have UTI. The patient probably has sepsis. So that's where the CDI comes in and query the doctor about about the diagnosis of sepsis so that the admission is not going to be denied, right? So this is another way of the DRG validation, or you could call it clinical validation.
Because you
So
would,
to be able
just
to justify.
with just this information, you would just have a PDX of metabolic encephalopathy.
That's right. Yes, but if the doctor diagnosed with patient UTI, the coders will just
The
put
UTI's
UTI
PDX, right?
as a PDX. So it's a problem because once the RAC or even the MAC
Right.
will audit right away, they will deny the admission. So
Yeah, on the
so we
UTI,
want to
you
make
won't
sure
put
that we
PDX.
Right.
that's right. So you want to coordinate with the case manager with this one so that the inpatient admission is not going to be denied. So you're right. So sepsis should be queried. So that would be the primary diagnosis, like sepsis due to UTI, right? So what else? And then the metabolic encephalopathy, right? He documented metabolic encephalopathy, and but I think that is the patient has UTI, but the thing I'm getting it at is there is no mental status.
Right.
The
Oh,
patient was
yeah, they
admitted
didn't document
confused.
anything.
So
Yeah.
They didn't document
yeah, so we want to
the
make
baseline.
sure that it's back to normal. Probably the sepsis or the UTI is still not being but usually, if they start the patient antibiotic, gradually the mental status is going to be back to normal. So you want to make sure that there's a documentation, even not in the progress note, in the nurse's notes, if there is like more alert now or more oriented, so at least you know that there is a progress in the mental status. So that would be the two DRG validation that you want to look at.
And linking the metabolic
Okay.
encephalopathy to the underlying etiology, which is probably the UTI, right? So that's
Yes. Yep. Okay.
all right.
Case number 5 is the 67-year-old female who was diagnosed with acute cholecystitis for laparoscopic cholecystectomy. The patient developed atrial fib at 150 with rapid ventricular response. Doctor documented assessment as acute cholecystitis. Op report is lap cholecystectomy. Plan admit to telemetry, cardio consult, start cardism, EKG stat, routine vital signs, Tylenol PRN for pain, and DCIV after completed. Hospital number 3 converted to sinus rhythm, incision clean and dry, afebrile, ready for discharge. So what is a clinical validation here?
What was the original doc? I can't see. I don't know.
Oh, you can't see it?
No. But
Oh,
I'm thinking with the procedure. And they use cardism?
okay.
Oh, okay, there it is.
Yes.
Oh, okay.
Mhm.
You get it up? Yeah.
Yeah, I got it.
Okay.
Mhm.
Well, that's tricky. So you're gonna, the only thing I see, because the procedure was routine, would be the atrial fib.
Very
Acute
good. So that's also the same. That's right, because laparoscopic cholecystectomy is an outside procedure, right? Outpatient procedure, I'm sorry. Outpatient procedure. But that's what the doctor has been documenting is acute cholecystitis. That's not exactly why the patient was admitted as inpatient. The patient was admitted because atrial fib. So you want to make sure that he documents that the patient was admitted due to atrial fib. And then the acute cholecystitis will be your secondary, and your surgical diagnosis would be your laparoscopic cholecystectomy, right? So yeah, so that's where because what happens if this patient is the patient's discharged, submitted the bill, the whole inpatient admission is denied. You cannot even convert it anymore to an outpatient because since it's not in an inpatient list for that procedure, so they will deny the whole procedure because
say.
you can only, as far as I know, you can only change the patient status inpatient to outpatient within the hospitalization, not
Correct.
after. So,
Yes.
and so that is, so you're right. So atrial fib is the validation, clinical validation to make sure that is the primary diagnosis
Right.
why the patient came. Okay.
So the workup would be more like this patient would have been sent from a
Could
facility.
be what?
He would have been sent into to be monitored for atrial field following the procedure because the procedure they will want to do the procedure so that they can monitor him because of atrial field.
That's right. Yeah. So
Right.
that's right. After the procedure, actually, if the patient didn't have atrial fib, the patient will go home. So it's an outpatient procedure.
Right,
But since the patient
exactly.
developed atrial fib, yeah, so they need to admit the patient. So that would be your PDX.
So the verbiage in the
So
doctor's
that's what. Yeah.
Yeah,
We lost
he
him.
lost connection again. So
Yeah.
can you hear me now?
cool. There you go.
Yeah. Mm-hmm.
Important for this.
Yeah. So
Okay.
the verbiage, like you said, would be the patient's admitted for atrial fib post laparoscopic cholecystectomy,
Right.
something like that. So to be clear to the auditor, if it gets audited, that the patient was admitted due to AFib rather than acute cholecystectomy.
Cholecystitis.
Mm-hmm. So that's the validation that we need to look at, right? So the inpatient admission is going to be valid. Okay. And that's it. So we gave you some examples on what the validations or what are the common denials that we get is usually like we had an example about the MCC, the sepsis, the CC, as well as the inpatient admission. So more or less you would know what are the types of what do you call this denials that's out there. There are more, but more or less we're giving you just the example.
And then why clinical validation is so important, or DRG validations for the HIM department.
Do you have questions?
I have 1,001 questions, but yeah, I'm good.
Okay.
1,001 questions.
All right.
So I wanted to ask something real quick. So two things. You said something about home health in the beginning. Like, why is that important to follow up on a review? And then the other thing with borderline diagnosis. So just if they say like mild or borderline something, to still diagnose that as a diagnosis.
You can
Those two
still
things.
code that right for borderline diagnoses. If they're getting treatment, then you can code that particular diagnosis. And they're saying borderline. Well, sometimes they'll say pre-diabetes, right? And then they're saying, well, they're borderline type 1.5, the latent adult onset diabetes, whatever. Okay. Or it could be borderline type 2 diabetes. If they're treating that, if they're doing workup for it, they're running blood glucoses every day, or they're doing finger sticks, AC and HS, then you can code that type 2 diabetes, even though they're saying borderline. Now, when it comes to your discharge disposition, it's important that the coders get that right, because the reason being, Medicare monitors that. For all their Medicare beneficiaries, they want to make sure that the discharge disposition is correct, because they pull that data for other external organizations and monitor what type of care these patients are getting after the hospital stay and what type of continuity of care is needed for that patient upon discharge. So it's not just about following up with your provider, your PCP, or your specialist after you're in the hospital for whatever reason, but they want to make sure that they're getting the appropriate care out in the community, especially, say, for example, a new diabetic. You got a 22-year-old who's a new diabetic, and they're diagnosing that patient, that 22-year-old female or male, with the type 1. It's a late onset because usually your type 1 are juveniles, right? But they want to make sure that that patient has the care that she needs in the community, that she's getting the care she needs. And they have to follow up with her as a new diabetic. You want to make sure an endocrinologist is involved. So is she going to get some home health? Maybe she'll get a home health nurse eval, just to make sure she knows how to do her finger sticks. She has all of her equipment to check her diabetes. She makes sure maybe she's on insulin, or maybe she's on an oral med. Where is she getting her medications filled? Are they covered by the insurance? So that's why I say discharge disposition. It's just good to make a note of it. If the patient is going to go to a SNF, or is the patient going to get home health, within your record. So that way the claim, when the coders are completing that claim information, they have some information from us that we're saying, hey, here's the discharge disposition. They're going home with home health, whether it's a nurse or therapy or whatever. Make sure you get that accurate. It's not self-care for that patient. They're going to have some type of home health come in and monitor them. And it's all about continuity of care. Because once they're discharged from the hospital, even though we took care of the acute issue, right? The new onset diabetes, and she was on an insulin pump for a while, but now we got her stabilized. Now she's going to go out to the community, but she has to know how to monitor her diabetes. She has to know how to treat her diabetes. So that's why it's really important that we look at, okay, where are they getting discharged to? Because the end result, it'll help the coder with the final coding. And believe it or not,
Another
Medicare
thing,
is taking money back if the discharge disposition is not accurate on the claim.
yeah. So because, like, for example, you know how Medicare is, they'll just give, like, for example, a diagnosis, 5-day stay, and then you discharge the patient home health, right? That, for example, on the second day, you said the patient can go home with home health for wound care, right? And then you put there, and you didn't put the disposition. It could be denied because you billed for the whole DRG when actually the patient only stayed for 2 days. So because there is what you call shared cost,
Right.
so the hospital can only get paid for 2 days, because since the patient is discharged on the third day, then home health should be getting the rest of the DRG payment or reimbursement. Right. So that's why it's important what is the disposition, because they would sooner or later the Medicare would know where did the patient go, because you bill for the whole DRG and then home health is also billing. So it's like double dipping on one DRG. Right. So it becomes a problem. So that's why also it's important for the disposition for home health. So Medicare would know that, no, I'm not paying the whole DRG. I'm just paying you for 2 days. So they will divide whatever the reimbursement is into 5 days, and then give the hospital the 2 days reimbursement and the 3 days for home health. So that's why the home health is also important. Whatever, not only home health, like if the patient went to the SNF, or the patient went for rehab,
Right.
Anything that has skilled needs, because the Medicare is not going to pay the full amount if the patient got discharged. It's usually like on the 4th day, let's say it's a 5-day stay, on the 4th day, it's okay already. But if you discharge the patient on the 2nd, 3rd day, they will not pay you the whole amount. Right. So that's what it is.
Makes sense.
Okay.
Yes, it does. Okay, so then the last thing is this whole sepsis 3.
Uh-huh.
So the question I have about sepsis 3 is you listed respirations, platelets, Billy, MAP, and creatinine. So when I'm building a case for these, should I start to be more inclusive with those 5 little things that you guys talked about in terms of like validation? to kind of start to fall into that whole sepsis 3 criteria?
Yeah, well, it's facility, right? So what do you guys do with Optum 360 with Dignity Health Hospitals? Do you have a particular protocol to follow sepsis criteria? You know, at Henry Mayo, for example, we have sepsis 2 criteria based on CMS, right? And most of our population admissions are older adults. So we have a lot of Medicare recipients, right? 60%. However, we started incorporating the sepsis 3 criteria with the sepsis 2 criteria so we can capture the information so that way we prevent the denial down the road. Okay. So it always goes back to what your facility policy is. And believe it or not, we have a template that we created. I created in my old supervisor. We put a template in the progress notes for the providers. It's in their favorites. And they have the sepsis 2 and sepsis 3 criteria listed out. All they got to do is point on it and give us the information. We even have acute organ dysfunction with the most common diagnoses listed, and then they point it out. And if it's other, they just type it in free text in their notes. So now we incorporated with the sepsis 3 criteria and the sepsis 2 criteria a template for the providers that they can pop it in their HMP, they can pop it in a progress note, they could even put it in their discharge summary if they wanted with that criteria. So I think it's all about education, but it's also what policy do you have in place at your facility? That's a big piece of the pie. And you know what? The medical executive committee agreed with having templates for these providers to make it easier for them for capturing accurate diagnoses. So when it goes to your medical executive committee, it's like, wow, okay, they even approved it. You know, we needed the medical staff approving it, and they did. And MEC even agreed with it, doing things like this. So, you know, I really think that if you don't have your senior leadership involved, you're going to have problems down the road with the CDI team and with coding and whatnot. And I see that, you know, and you have to have their buy-in. And if you have a medical director and you got a physician advisor who works well, collaborates with the medical director of, you know, the medical staff, you definitely want to collaborate all the way around. And that keeps the CDI team and all the coding going, moving forward the way it should be.